Hi, well, thank you so much for having me today. This has been a fascinating debate. So I wanted to just ask, let's say that there are some very thorough doctors who have checked their internal biases and have determined that their adolescent patients' health might very much benefit from these more intensive treatments, anti-obesity medications, bariatric surgery, even, just mental health counseling. These are expensive and time-consuming treatments. How do we ensure that kids and teens in lower socioeconomic households even have the opportunity to participate in these kinds of weight interventions?
Julia, do you want to take that first?
Sure. This is like a crazy evolving landscape. Yes, these medications are very expensive. And I practice in California, and in this kind of beautiful twist of irony, I'm able to access important treatments for kids and offer them. And I have fewer insurance barriers on kids who are on our health plan, who have poverty and who qualify for health plans. So it's just one of those strange but wonderful opportunities that I have. And it's interesting that the harder times I have when I want to advocate for a child to receive treatment because they have severe disease, they have complications, when my clinical judgment and working with the family, I will say this is always shared decision making, that the benefits of treatment along with the risks of treatment outweigh the risks of not treating and the benefits of not treating. So we're always doing this very, very careful weighing. The money is a really, really big issue. It will change when some of these medications come off patent, when they're more available. We could talk a lot about the pharmaceutical companies and the price gouging, and it's a really huge problem. That's a whole other conversation that should be had. What is going on? Why are these treatments not universally available?
Let's use that point to let Janna jump in if you'd like to on the same question, Janna.
Yeah, I'm glad you brought this up as an equity issue, because I think it is an equity issue across the board. The drivers, as this guideline, and I think we agree on this actually, the drivers of obesity are of obesity as a number, and also of the correlating diabetes and heart disease, are in fact structural inequities in our society. A lack of access to nutritious foods, structural oppression, trauma. In fact, we know that discrimination, racism, all of those increase the stress response, which, as we've talked about, is a physiologic part of all of this, right?
Absolutely.
So these structural inequities are a driver of the diseases that Julia and I both have talked about, and also of this higher BMI and this distribution in weight. There's also cultural, racial, and ethnic differences in the way that bodies are and their sizes that are here, and that also contributes to some inequities. I want to note that earlier on, I was not implying that anyone individually in any of these doctors' offices is individually inherently racist. It's that the structures of BMI itself is an inherently racist measure. It's embedded in there. Just by the way that it's there. Now, on to your really good question, which is, even in a society where every single doctor has grappled with their own weight stigma, which I wish would happen. I think we both actually wish that would happen, because we're both there. Like, I think we agree on that. We're talking about the three interventions that we're talking about are intensive behavior and lifestyle treatment. That was one that was recommended by the AAP, which requires, of note, 26 plus hours of face-to-face time over the course of 3 to 12 months, which, as somebody who works primarily in a predominantly almost all public insurance or uninsured practice, and also works with youth experiencing homelessness, nearly impossible for almost all of my patients to physically implement. And
Absolutely.
Also, again, there's that rebound weight gain right after, because it's remarkably difficult to sustain. And then there's these very expensive medications and also bariatric surgery, which, again, this is driven, I just want to name, by a large capitalist enterprise that has convinced us that we need to be aggressive here. That's part of this, and also has a lot of profit to gain from this. So yes, we have the equity issue is the driver of obesity in the first place, but there is also an equity issue in who can actually access these, and who can access the foods that we're talking about, and who has access to green space, and who has safe communities, and who is experiencing a tremendous amount of toxic stress related to various intersecting identities of oppression, like being Black, being gay, being queer, and being fat.